role of remdesivir, so I'll concentrate on that part. For this particular talk, I have no conflicts that I need to disclose. And like I said, I will concentrate on the role of remdesivir, and we will talk about 4 clinical trials which are pivotal in understanding the role of this drug in the management of COVID-19. I will not go into the other drugs which Dr. Adeel has already mentioned. The trials that I'm going to talk about are ACTT1, the Adaptive COVID-19 Treatment Trial, the first study on this, and then ACTT2, the Simple Trial, and the Solidarity Trial. Many of them have been, the first 3 have been supported by National Institutes of Health and National Institute of Allergy and Infectious Diseases in the US. So these are some of the potential therapeutic agents for SARS-CoV-2 and COVID-19 infection that Dr. Adeel very eloquently went over. Remdesivir, steroids, monoclonal antibodies, and IL-6, IL-1 blockers have a possible or a definitive role in the treatment of these infections. However, previously recommended therapies like hydroxychloroquine, azithromycin, lopinavir, ritonavir, interferon have absolutely no role based on several randomized clinical trials that have been published now. Convalescent plasma has a questionable role, but a more recent clinical trial shows that it showed no benefit. And some therapies that have been advocated by politicians and non-physicians and non-medical personnel like bleach, ultraviolet light, and other such things obviously have no role in the treatment of COVID-19 and SARS-CoV-2. Now, remdesivir, some of you may know, is a prodrug of an adenosine analog. It has demonstrated antiviral activity against several RNA viruses, including the original SARS-CoV, as well as the Middle East Respiratory Syndrome virus, or MERS-CoV. It works by inhibiting viral RNA-dependent RNA polymerase, and it has shown nanomolar activities, in vitro activity, as well as activity in non-human primate models against SARS-CoV and MERS-CoV. So I will go straight to the clinical trials that we're going to talk about because there is a fair amount of information and time is relatively limited. We will start off with adaptive COVID-19 treatment trial, the first part of the first phase called ACTT1. This was a phase 3 adaptive randomized double-blind placebo-controlled multi-center global trial. Key inclusion criteria for this trial were that patients needed to be adults who were hospitalized with confirmed SARS-CoV infection, and they should have had some symptoms, plus evidence of pneumonia on either X-ray findings or CT findings, and or clinical assessment with an oxygen saturation of less than or equal to 94% on room air. So people or patients could either be requiring or needing supplemental oxygen, invasive or non-invasive, and requiring mechanical ventilation. They enrolled 1,063 patients, and they were randomized into 200 milligrams of remdesivir on the first day at the loading dose, followed by 100 milligrams of remdesivir for 10 days after that. And the primary outcome, I'm just going to move this slide. The primary outcome was time to recovery, which was measured as any recovery between day 1 and day 29 on an 8-point ordinal scale, which is listed out here. So this scale goes from a score of 1, which means patient has no limitation of activities, requiring no treatment and is not hospitalized, to the other extreme, which is a score of 8, which means the patient died because of the disease. Initial primary outcome, as I mentioned, was difference in clinical status between remdesivir and placebo at day 15, defined on the 8-point ordinal scale that I showed you in the last slide. They amended this a little bit later on to time to recovery, anytime between first day and the first 28 days after enrollment, in which a patient achieved a category 1, 2, or 3 on the scale that I showed before. So in other words, patient who became asymptomatic, was discharged, or had no therapy that he required or she required, was considered as a success. And secondary outcomes included mortality as well as difference in clinical status. And the trial was designed to achieve 85% power for detecting a recovery rate ratio of 1.35 which means approximate 35% benefit that would be seen by use of remdesivir. This is the flow chart of the study enrollment. They screened 1,114 patients and 1,062 were randomized. After accounting for inclusion and exclusion criteria, there were 541 patients in the intent to treat population in the remdesivir group, and there were 521 patients in the placebo group. The number for as treated analysis was 532 in the remdesivir and 516 in the placebo group. These are the baseline characteristics of these patients. And I'm not going to go into the details of everything except to point out that there were no major differences in baseline characteristics between the two groups. 89% of the patients had severe disease at the time of enrollment. This is important to understand that a large proportion of people had quite severe disease. These are the results for the primary endpoint or time to recovery. And here the results were stratified by patients receiving oxygen or not receiving oxygen, and various type of oxygen delivery. For example, receiving high flow oxygen or a non-invasive ventilation, or those requiring mechanical ventilation. So first of all, in panel A, you see that overall there was a benefit of remdesivir over placebo in time to recovery. This benefit was mostly driven by patients who were receiving oxygen, but not those who were receiving oxygen through mechanical ventilation or high flow oxygen. Also, patients who were very mildly ill and not requiring any oxygen at all also did not have any benefit from remdesivir. This is a summary of various subgroups as to which groups benefited the most. So as you can see on the top, when you look at all patients taken together, there was a significant benefit of about 30% or so. Subgroups that had benefit remdesivir included those who had an infection or symptom duration of less than or equal to 10 days, those who were receiving oxygen, but not those who were receiving mechanical ventilation or invasive ventilation of any other sort or high flow oxygen. So if you want to summarize this, younger people with shorter duration of symptoms requiring low flow oxygen or oxygen by nasal cannula are the ones who benefited the most. And those who had longer duration of symptoms, those who had very mild illness, or those who required very high flow oxygen and mechanical ventilation did not have benefit. These are the results for mortality difference between the two groups, and this difference was not statistically significant. In the remdesivir group, 7% of the patients died by day 14. In the placebo group, 12%. And while this is numerically quite different, this did not reach statistical significance. So moving on to the second part, the ACTT2 trial, which included an immunomodulator baricitinib in addition to remdesivir versus remdesivir plus placebo. These results have not been published in peer-reviewed journals, but these have been published on various websites and through company press release. So that is where, and also on the FDA website, that is where I got some of this information from. Now, baricitinib is a Janus kinase inhibitor, and Janus kinases are cytoplasmic tyrosine kinases, and there are multiple different types. They also inhibit numb-associated kinases, which are again cytokines which are in the pathway for immune modulation and blunting of inflammation. So in this diagram, you can see that baricitinib inhibits both JAK1 and 2, as well as other Janus kinases or numb-associated kinases called AAK1 and GAK. And these probably have some role to play in the propagation of the virus in humans. So that was the rationale for including baricitinib in addition to remdesivir in these clinical trials. Inclusion criteria were quite similar to the ACTT1 trial. These were adult hospitalized patients with illness and one or more of the following conditions. They had to have pneumonia by chest imaging, oxygen saturation of less than 94% on room air, or requiring supplemental oxygen or on mechanical ventilation. This trial enrolled 1,032 patients, and patients got remdesivir plus baricitinib or remdesivir plus placebo. And the outcome was time to recovery, as mentioned previously in the other trial. In terms of baseline characteristics of patients, the mean age was 55 years, and 1/3 of the patients were more than 65 years old. And these are the patients who are expected to have a higher mortality and higher rate of complications. 14% of these patients were not on any supplemental oxygen. A little over half, or 55%, were receiving supplemental oxygen, and 32% were getting either high flow, non-invasive ventilation, or were on mechanical ventilation. A fair number of these, more than half of these patients, had comorbidities like obesity, hypertension, and diabetes. In this trial, the median time to recovery was 7 days for the baricitinib plus remdesivir group versus 8 days in placebo group, which received only remdesivir. So this was, while the difference number is small, this was statistically significant difference between the two groups. In terms of a composite endpoint of who died or progressed to non-invasive ventilation, high flow oxygen, or invasive ventilation, 23% in the baricitinib group and 28% in the placebo group achieved that endpoint. And this was also statistically significant. However, if you looked at mortality alone, this was not different between the two groups. So the next study we'll talk about quickly is the SIMPLE study. And this study looked at a 5-day versus a 10-day course of remdesivir in patients with severe COVID disease. So in this trial, this was a phase 3 randomized open label multi-center international trial, and the inclusion criteria was slightly different. This included hospitalized patients, and for the first time, they included younger patients between 12 and 18 years of old, as well as adults. But these younger patients who were between 12 and 18 needed to have a BMI, a body weight of more than 40 kilograms. They also needed to have an oxygen saturation of 94% or less on room air, or requirement of supplemental oxygen, and evidence of pneumonia on chest X-ray or other radiological investigation. So part A of this trial is what we're going to talk about. Is 400 patients were enrolled, approximately 200 in each group, and they got either remdesivir 200 milligrams, followed by 100 milligrams for 10 days, or remdesivir 200 milligrams loading dose, followed by 100 milligrams once a day for 5 days. And the primary endpoints again was clinical status assessed by 7-point ordinal scale on day 14. This trial was designed to provide more than 85% power to detect a difference or a rate ratio difference of 1.75 in odds of improving outcomes. And efficacy and safety were assessed in all randomized subjects who received one or more doses of this drug. This is the enrollment and randomization table for this study, and 408 patients were assessed for eligibility, and almost all of them, except a few, were actually included in the analysis. 200 in the efficacy and safety analysis, and 197 in the analysis on the 200 in the 10-day group, and 5-day group, and 197 in the 10-day group. These are the baseline characteristics of the two groups. Again, the characteristics were balanced, but a greater proportion of patients in the 10-day arm were in higher disease severity category, meaning those who received 10 days had slightly more severe disease compared to those in the shorter treatment group. So this is the main result, which is clinical status at day 14. And in both groups, the observed rate of clinical outcomes was similar between the 5-day and the 10-day group. So in other words, 5-day treatment with remdesivir was as effective as a 10-day treatment course in terms of clinical status recovery in the patients. Now, when you break these results down by severity of disease, in other words, what was the oxygen status at the time of starting the trial, it seems that all mortality and all severe effects occurred in people who were very severely ill or required invasive mechanical ventilation at the beginning. On the right-hand side, the 4 bars on the right-hand side are people who received low flow oxygen or were not on any oxygen. And you can see that there was almost no mortality in these patients. And most of them were discharged home. It is this group on the left-hand side, which were on mechanical ventilation, who had high rates of mortality and were requiring high flow oxygen or mechanical ventilation. In terms of safety, the drug was relatively safe. Common side effects included nausea. Some people developed acute respiratory failure, but that probably would have been expected from the underlying disease itself as well. A proportion of patients develop liver enzyme elevations, and a small percent of people, but between 2 to 8%, showed acute kidney injury or a rise in creatinine. And these were slightly higher in the 10-day remdesivir group compared to the 5-day group. So in other words, the summary of this is that 5-day treatment with remdesivir is as effective, but with lesser side effects. So let me finish off with this WHO Solidarity trial, which has created a lot of buzz in recent weeks and has led WHO to issue new guidelines regarding the use of remdesivir. I must caution you that these results have not been published in peer-reviewed journals yet, and the source of information is a non-peer-reviewed preprint server like medRxiv website, where they have posted these results, and there have been a lot of press releases which have touted this. Now, this was an open-label trial which used any of the approved or commonly used drugs in each of the countries that participated in the trial. So these included remdesivir, hydroxychloroquine, lopinavir with ritonavir, interferon beta. So anything that was being used at that point in time was included in this study. Patients were randomized equally between whichever study drugs were locally available, and they were all open label enrollments. The intent to treat primary analysis were of in-hospital mortality in the 4 pairwise comparison of each study drug. In other words, remdesivir was compared with non-remdesivir group, hydroxychloroquine was compared with non-hydroxychloroquine group, and so on and so forth. And mortality was measured at 28 days. This is a complicated slide, but just shows the type of enrollment that happened. What we're interested today is the remdesivir group, which is on your left-hand side. 2,750 patients were enrolled in this group. And this is the group that we're going to talk about today. Again, you may not be able to see this very clearly, but this gives some of the baseline characteristics of each of the group. About a small proportion of patients, 500 out of the 2,700 in the remdesivir group were more than 70 years of age. Smaller number required respiratory support at the time of beginning. And I will go over all comparisons. From remdesivir versus control showed no difference in 28-day mortality. Hydroxychloroquine versus its control also showed no difference in mortality. Lopinavir, ritonavir showed no difference in mortality. Interferon showed no difference in mortality. So all the 4 major treatment trials showed no difference versus their own corresponding control in terms of 28-day mortality. And these are the results that led WHO to recommend that remdesivir may not be very effective in treatment of COVID-19, something that we will discuss, and something that I disagree with to some degree. And these are the rate ratios of any death stratified by age and respiratory status at any time. And again, what you can see for remdesivir, which is top left-hand side here, that they showed that there was no difference in these endpoints in remdesivir versus control group, but also all the other treatment groups showed no benefit in mortality when broken down by these parameters. This Solidarity trial investigators also did a meta-analysis of studies published till that time of remdesivir versus a control group. And they found that of those pooled studies, they found no difference in terms of endpoints of clinical improvement or mortality. Now, it must be noted that this meta-analysis is heavily skewed towards the Solidarity trial because this included the largest number of patients. The other trials like ACTT1, ACTT2 were randomized control trials, placebo-controlled trials. And because they were such rigorous trials, the number of patients enrolled is generally smaller in these kind of trials. So what is the interpretation of all these complicated data of all these drugs that we talked about? So here's my take on that. I think that remdesivir cannot and should not be written off at this point in time. There are several well-designed randomized clinical trials, which are the gold standard, which have shown a benefit in certain subpopulations of patients infected with SARS-CoV-2 virus. So these patients include those who are hospitalized and have evidence of pneumonia, those who are receiving oxygen, but not those who are on mechanical ventilation. So in other words, if the disease is very severe or very mild, meaning patients are not in need of any oxygen, or on the other hand, are ventilated, these patients do not have benefit. But those in the middle who have mild to moderate disease, who require oxygen, but only through, for example, a nasal cannula, they are the ones who are likely to benefit based on at least 2 and perhaps 3 randomized clinical trials. Those who present to you earlier in the disease, in other words, those who have symptoms for 10 days or less, are likely to respond more. So this is a subgroup that you can concentrate on more in terms of giving remdesivir. Those who are younger, between the age of 18 and 40 years, are likely to respond better. So if I was to recommend remdesivir, this is the sort of population I would give it for. Those who are presenting early, those who are particularly younger, but I would not limit it to that. Those who have lower oxygen saturation in room air and require low flow oxygen and have evidence of pneumonia. Steroids have been shown to benefit those who are critically ill, requiring either oxygen or invasive or non-invasive mechanical ventilation. In patients who are not critically ill, steroids have questionable benefit, and it's not very clear what their use is. Monoclonal antibodies like casirivimab and imdivimab, they need to be administered together. These are for mild to moderate disease and for patients who are not on oxygen, not on mechanical ventilation, and not hospitalized. In other words, people who are very early and very mild in their disease. And this is for prevention of more severe disease. Biologics like baricitinib need to be administered with remdesivir because that is the only clinical trial that has been published so far. These are for hospitalized patients on supplemental oxygen, including those who are on mechanical ventilation and show pneumonia on chest X-ray or low oxygen saturation. So this is where I would stop with the word that remdesivir cannot and should not be completely disregarded based on WHO guidelines right now. I think there are some good studies, very well done randomized clinical trials that show benefit. However, the benefit is in specific subpopulations, so you have to choose that patient population carefully. So I will stop here and I will stop sharing my screen and hand it back to our moderator so that if there are any questions, I'll be happy to answer them.
Thank you very much, Professor Adeel Ajwad, for your presentation. And now we